I think ultimately what we all want to know is whether this technology can change our clinical outcomes, our performance, our efficiency, and our ability to keep patients safe, especially in the ER setting and OB settings. So my partners and I did design the POCUS study. We worked with experts in human factors to conduct a time and motion study on a busy labor and delivery unit to find out how access to, in this study, we actually did use the butterfly IQ, so how butterfly impacted our workflow. The primary outcome was clinical decision time. So we are looking at the time the decision is made that you need an ultrasound to the time that you make a decision. And so the first thing we did was create a process map by observing workflow. And so you can see that for personal device-based POCUS or handheld ultrasounds or pocket probes, whatever you want to call them, the process is very linear. So in the top row, you see a pretty streamlined process. You decide to perform an ultrasound, you have the device in your possession, you perform your scan, you make a decision. When you rely on a cart-based machine or a standard ultrasound machine, the process is less linear. So once you make the decision to perform an ultrasound, you have to go find the machine. And if it's not in the expected location, you get stuck in this loop of inefficiency, which I have outlined for you with the gray arrows. And similarly, once you have the machine and you bring it back to the bedside, a power source has to be identified. And again, there's this risk of getting stuck in another loop of inefficiency. All the outlets are taken or you can't reach it. You know, if you're an OB, you've definitely crawled on an L&D room floor to find a power outlet. It's part of residency training. But once you have that power supply established, then the device has to load, and then you can perform your ultrasound to make a clinical decision. So there are more steps required to perform bedside ultrasound when you rely on cart-based machines compared to personal device-based probe. You also have a higher rate of redundant patient encounters is what we found, where a clinician would present to the bedside, complete their history and physical exam, and then return to the bedside for a second time for the sole purpose of performing ultrasound. So what we wanted to know was if this really matters, like these theoretical loops of inefficiency, and not just in terms of physician happiness, but clinically, do they matter? And so we quantified it. And you can see on this very busy slide that it does. And the big picture is that we found that clinical decision time took around 9 minutes when using a standard machine compared to 2 minutes when you have access to a handheld ultrasound. And, you know, the reason why really is because in the graph, you can see the blue and gray in the graph depict pre and post scanning tasks. So that means time spent on non-clinical tasks like locating machines, cleaning them, finding power sources, all the tasks that we outlined in the process map that take up clinician time. But the thing that was really important to me was that if you take a look at the orange in the figure, the amount of time actually spent scanning was the same between groups. Statistically, there was no significant difference between the time spent scanning. The labor and delivery unit where this study was performed, the census is around 7,000 deliveries per year. And every one of those patients underwent at least one ultrasound during their admission. So if you present to labor and delivery, we make sure that baby's head is down. So by my most conservative estimate, where each patient is truly only scanned once, we saved 51 hours of direct physician time per month by incorporating handheld ultrasound into our practice. And to be transparent and realistic, we scan patients probably 2 to 5 times throughout an entire labor and delivery course between admission through delivery through postpartum care. And then on top of the labor and delivery service, most units also offer full OB triage services. So in this hospital setting, that was 400 visits per month. And so that was an additional 33 hours of physician time saved per month when using handheld devices. And so this is an example of an abdominal circumference at 26 weeks. So one of them on the left is with, in layman's terms, a very fancy ultrasound machine. And then on the right, you can see the same fetus at the same gestational age. And you can see that you can see all the same landmarks that you need. And so, you know, I also did do a validation study, but this is just an example so you can see for yourselves what it looks like on the 2 machines. This is my baby, actually. She's born now, but, you know, anyways, her abdomen was appropriate for gestational age, and that was confirmed with both a pocket probe and a standard machine. So that's just a little bit about the pocket study and the way we truly quantified the difference that it makes. And then just to kind of highlight other things, you do a lot of things with these devices in the obstetric setting. Here's an example of confirming that you have a 3-vessel cord. And so again, on the left, you have the fanciest machine, and on the right, you have the teeny tiny machine. And you can see that regardless of which probe you're using, you can confirm a 3-vessel cord. We've had a really good experience just integrating this into practice, but we wanted to do this study before we integrated it because we wanted to know, it's a big change to our day-to-day workflow. Is it worth it? And the answer was yes.